Okay, let me get you into the mindset here. The setting is Egypt, the year 1936. Legend speaks of an ancient Egyptian pharaoh who had hidden a powerful relic in a city consumed by a sandstorm long ago, and it has been the obsession of archaeologists ever since. So begins our vancomycin sketch. Vancomycin is a glycopeptide antibiotic active only against gram-positive bacteria such as staph, strep, C. diff when used orally, and Enterococcus species, but not VRE. And if you look closely, you may be able to spot some ancient Egyptian temples among these ruins. They're purple for gram positive. One of the most important indications for vancomycin, of course, is in bloodstream infections caused by methicillin resistant Staph aureus, or MRSA. In previous sketches, MRSA was always associated with the mercy of a golden staff wielding pharaoh, and it looks like he's back, the guardian of the relic that has fallen into the hands of our courageous and undeniably attractive explorer. Take a look at the main temple from which our explorer is narrowly making his escape. It's spherical and purple in order to represent the gram positive cell wall of Staphylococcus. And what have we got here? He's clutching on to none other than the legendary golden staff, Aureus. And of course, our explorer came prepared with his getaway van. Those of you familiar with our sketchy micro course have seen a van pop up in many places where vancomycin is an antibiotic of choice. Of course, we here at Sketchy utilize careful antibiotic stewardship, using vancomycin only when the strain is susceptible and there are no other alternative drugs to reduce resistance. It's especially appropriate here as our explorer makes his escape and has enough room in the trunk for his collection of relics. Notice that our explorer is using a whip to attach directly to the temple wall as he swings to safety. That's because vancomycin directly inhibits cell wall synthesis by binding firmly to the D-ala-D-ala terminus of nascent peptidoglycan peptides. And if we look carefully, we can see the D-ala-D-ala hieroglyphs carved into the structure of the temple wall. I know what you're thinking. We've seen this D-ala-D-ala motif before. In our previous sketches that toured the beta-lactam antibiotics, we illustrated how penicillins halted peptidoglycan synthesis in the bacterial cell wall. But instead of binding directly to the peptidoglycan, penicillins bind to the PBPs responsible for peptidoglycan synthesis, represented by builders constructing the cell wall. That's why the anti-staphylococcal penicillins, such as nafcillin and oxacillin, can be thwarted by staphylococci that alter these PBPs, making beta-lactams unable to bind. In fact, we have one of these altered penicillin binding proteins here, represented by one of the MRSA pharaoh's mind altered minions trying to build the temple wall and trap our explorer inside. But these methicillin resistant staphylococci can alter their PBPs all they want. Vancomycin, like our explorer's whip, directly binds to the D-ala-D-ala peptidoglycan structure, inhibiting cell wall synthesis and killing the cell. That means it's bactericidal. Vancomycin is also resistant to beta lactamases, those pesky plasmid encoded guards that were shooting down the penicillins in our previous sketches. And here we have a person guarding the temple, adorned with these ring shapes to evoke something encoded by plasmid genes. He's shooting darts at our explorer, who's frankly desecrating the sacred temple, but they deflect away harmlessly. And notice that our explorer is swinging on a vine made of ivy. Vancomycin is almost always administered intravenously, and it's widely distributed in the body, including the CSF, during meningeal inflammation. So, vancomycin is often combined with ceftriaxone for the empiric treatment of meningitis until culture and susceptibility results are available. This is because of its effectiveness against penicillin resistant strep pneumococci. We'll include our recurring red meningitis mohawk helmet on our guard, whose beta lactamases usually confer resistance against penicillin treatment, but vancomycin has got you covered. If healthcare acquired meningitis is suspected, vancomycin plus an anti-pseudomonal beta lactam like cefepime, ceftazidime, or meropenem is recommended as empiric therapy. Vancomycin even penetrates into bone to treat MRSA osteomyelitis. Remember that vancomycin is one of your big gun antibiotics used to treat serious systemic infection, especially in hospitalized and immunocompromised patients who are at higher risk for multi-drug resistant microbe infection. Additionally, patients presenting with hospital-acquired pneumonia may be at higher risk for nosocomial MRSA infection, and vancomycin can be added to their regimen. So remember, the addition of vancomycin or other MRSA coverage may be important in hospital settings. That's represented by this nurse waiting beside our explorer's getaway van. Notice the lung stains on her uniform as she coughs from the desert sand, and that'll represent hospital acquired pneumonia. That's just one example of nosocomial MRSA infection. Vancomycin is effective against most pathogenic staphylococcal infections, including staph epidermidis, which forms biofilms on hospital IV lines and prosthetic devices like heart valves. But it looks like our getaway van isn't quite ready yet. Under the van is the inattentive, yet reliable repairman from the staph epidermidis sketchy micro video. Just like in that sketch, he's covered in gunky biofilm, as are the lines and valves he's working on. While endocarditis caused by methicillin-sensitive strains of staph, such as staph epidermidis, are often more effectively treated with an anti-staph penicillin like nafcillin, remember, naf for staph, vancomycin is first line for empiric treatment of endocarditis because of its broad and effective coverage of the usual gram-positive culprits like staph, including MRSA, strep, and sensitive Enterococcus species. Let's make the headpiece of the staph heart-shaped to remind you of the empiric treatment of endocarditis, both native valve with vancomycin alone and prosthetic valve with vancomycin plus rifampin and gentamicin. One thing to note about Enterococcus, an important cause of nosocomial UTI and endocarditis, is that vancomycin-resistant strains are becoming an important clinical concern, and you should check out our sketchy micro video for more info. Our recurring sketchy symbol for Enterococcus is our purple double bass drum player who's ready to rock, evoking the appearance of this gram-positive diplococcus. Notice this drummer is on top of another temple, more like a temple of trouble because of its altered peptidoglycan structure. Resistance to vancomycin in enterococci is due to modification of the D-ala-D-ala binding site on peptidoglycan. The terminal D-alanine is replaced with a D-lactate. So, as we can see, our last archaeologist who tried to escape this D-ala-D-lac temple became a permanent addition to that archaeological find, if you know what I mean. Vancomycin is poorly absorbed in the intestinal tract and administered orally only for treatment of colitis caused by Clostridioides difficile. Remember our sketchy micro C. diff sketch that took place in a diarrhea-evoking chocolate factory? We're going to keep the diarrhea flowing here in this inappropriately placed and historically inaccurate temple, with chocolate flowing out of a stone mouth. Remember, oral vancomycin for C. diff. Let's finish off this sketch with some adverse effects caused by vancomycin, most of which are relatively minor. Among the more common reactions is the vancomycin flushing syndrome, an infusion-related flushing caused by release of histamine. We'll sketch in an ancient Egyptian statue, flushed in red, and histamine-releasing mast cells will be represented here as a beehive hanging from the arm, ready to degranulate its contents at any second. Vancomycin flushing syndrome can be managed by prolonging infusion or treating with H1 and H2 antagonists like diphenhydramine and famotidine. Vancomycin is irritating to tissue, causing thrombophlebitis at the injection site, which we'll represent here by the blue vines creeping up the leg of the statue. Ototoxicity and nephrotoxicity are rare with vancomycin, but administration with another ototoxic and nephrotoxic agent, like aminoglycosides, increases risk. Notice the large gong above the statue ringing out as the alarm is sounded. One of the big ears adorning the sacred statue of Anubis is cracked and falling for ototoxicity, and a golden kidney-shaped plate topples from his flank. Vancomycin can also cause nephrotoxicity, shown here by that falling kidney. The risk of ototoxicity and nephrotoxicity may be more likely in renal impairment. Reducing the dose can reduce the subsequent risk. And remember, vancomycin should be stopped if tinnitus occurs. Consider monitoring hearing during long courses of vancomycin. Vancomycin, along with some anticonvulsants, allopurinol, and sulfonamides, can cause a rare, potentially life-threatening drug reaction with eosinophilia and systemic symptoms, or DRESS syndrome. It can occur 2 to 8 weeks after exposure with symptoms of fever, generalized lymphadenopathy, facial edema, and a diffuse morbilliform skin rash. The drug reaction can also include other organs like the liver, kidney, and lung. Since lab studies show eosinophilia, we're going to bring back our EO slingshot shooter with a bilobed mask and a pocket full of pink granules. And to specifically remember dress, let's put this person in a flowing eosinophilic dress. One last thing to note, 90% of the drug is excreted by glomerular filtration. So, therapeutic drug monitoring is necessary, particularly in patients with renal dysfunction or on multiple nephrotoxic drugs, to make sure that concentrations are therapeutic. To show the undulating plasma levels, let's draw some vans off in the distance traversing the red, undulating dunes. All right, let's sum up this sketch. Vancomycin binds directly to the D-alid-D-alid structure of peptidoglycans. It's effective in treating systemic gram-positive infections, including those caused by MRSA. It's given orally for C. diff, and its side effects include ototoxicity and nephrotoxicity, for which you might need to monitor drug levels. Overall, I feel like this sketch was pretty good. Definitely deserving of a few subpar yet quality sequels, though more than two may be a little excessive.